Good day everyone. Welcome again to another of my course lecture series. I am Paul, an icon assistant of Dr. Donaldo Tugbang. Today, I will be discussing about personality disorders. Before proceeding with the lecture proper, here are my learning objectives. At the end of the lecture series, you are expected to have a basic knowledge and understanding of what personality disorders are. You should also be able to differentiate each personality disorders by groups based on its general characteristics. At the same time, identify, recognize, and describe its own unique features. By having this basic knowledge and understanding, hopefully, you will learn and appreciate what personality disorders are, and how it can influence or affect our daily lives, and the people around us. To start with, let us define first, what is personality? The word, personality, originates from the Latin word, persona, which refers to a theatrical mask worn by actors, in order to perform different roles. While we tend to think of a mask as being worn to conceal one's own identity, the theatrical mask was originally used to either represent or project a specific personality trait of a character. According to the Diagnostic Statistical Manual 5, personality refers to a set of enduring and behavioral mental traits that distinguished a human being, based on its unique characteristic patterns of thoughts, feelings, and behaviors. It is believed that personality arises from within the individual and remains fairly consistent throughout life. To better understand how the term, personality disorder arises, let us do a short review about the history of where the concept of personality begins. The concept of personality has been studied for at least 2,000 years, during the ancient times. This was introduced by Hippocrates, in his theory of the four temperaments. Based on the theory, Hippocrates suggested that personality traits and human behaviors are based on four separate temperaments, which are influenced by the four fluids or humors of the body. In fact, he did not attribute mental illness or other diseases to evil spirits, but to physiological reasons, in terms of imbalances of circulating body fluids that also affected one's personality. These four fluids are as follows. 1. Choleric temperament, which represent as a yellow bile from the liver. 2. Melancholic temperament, represent as the black bile from the kidneys. 3. Sanguine temperament, as the red blood from the heart. And the last one, phlegmatic temperament, as the white phlegm from the lungs. Although Hippocrates' theory of temperament is the first written theory linked to personality and health written today, he took its origin in the even older Egyptian and Mesopotamian philosophy of humorism. Another Greek philosopher, noteworthy to mention is Theophrastus. In his book Characters, where he describes 30 character types that he saw as deviations from the norm, and similar views have been found in Asian, Arabic and Celtic cultures. The following table shows us the 30 character types observed by Theophrastus. We will not be discussing each and every one of this but just to demonstrate to you what those 30 characters are. Now to continue. Centuries later, the influential Greek physician, surgeon and philosopher, Galen, expanding on Hippocrates' theory, in his dissertation, De Temperamentis, he first typology of temperaments. He described in his dissertation, that both diseases and personality traits could be explained by imbalances in the humors of the body, and that each person exhibits one of the four temperaments. For example, the choleric person is passionate, ambitious, and bold. The melancholic person is reserved, anxious, and unhappy. The sanguine person is joyful, eager, and optimistic. And the phlegmatic person is calm, reliable, and thoughtful. Galen's theory was prevalent for over 1,000 years and continued to be popular through the Middle Ages. Not until the 19th century, with the advent of modern medicine, was Hippocrates and Galen's theory substantially challenged. Although it continued to be used by some researchers and practitioners until the 20th century. Physicians in the early 19th century started to diagnose forms of insanity that involved disturbed emotions and behaviors but seemingly without significant intellectual impairment, delusions or hallucinations. In fact, by the beginning of the 19th century, psychiatric patients became legitimate objects for research and personality. It was viewed under one theory or other, which tried to make sense of human behavior. The following are some of the theories which attempted to explain what personality is, and how it influences psychopathology and paved way to many varieties of psychotherapy. Here are only some of the personality theories which try to explain what personality is according to their school of thought. The classical psychoanalytical theory of Sigmund Freud. It explains personality as a composite of biological aspects, represented by the id. The psychological aspects is represented by ego, and the social aspects is represented by the superego. He elaborates further that humans' basic nature is irrational and selfish, and that only social prohibitions, including internalization of social rules, can restrain the individual's instinctive strivings. Freudian theory was so popular that it led to a number of followers, including many of Freud's own students, who developed, modified, and expanded his theories. Taken together, these approaches are known as Neo-Freudian theories. To mention some: Alfred Adler was a follower of Freud who developed his own interpretation of Freudian theory. Adler proposed that the primary motivation in human personality was not sex or aggression, but rather the striving for superiority. Adler believed that psychological disorders begin in early childhood. He argued that children who are either overly nurtured or overly neglected by their parents are later likely to develop an inferiority complex, a psychological state in which people feel that they are not living up to expectations, leading them to have low self-esteem, with a tendency to try to overcompensate for the negative feelings, in order to meet the goal of superiority. Carl Jung was another student of Freud who developed his own theories about personality. He believed that self-realization or learning to the fullest is the underlying motivation that guides a person for a successful personality development. Separately, Richard von Krafft-Ebing, an Austro-German psychiatrist, popularized the terms sadism, masochism, homosexuality, bisexuality, necrophilia and analingus in his book Psychopathia Sexualis, as psychiatric issues. In the early 20th century, a German psychiatrist, Emil Kraepelin, included a chapter on psychopathic inferiority in his influential work on clinical psychiatry for students and physicians. He suggested 6 psychopathic types. They are excitable, unstable, eccentric, liar, swindler and quarrelsome. On the other hand, a Scottish physician and psychiatrist, David Henderson, published in 1939 a theory of psychopathic states which ended up contributing to the term and becoming popularly linked today as antisocial behavior. Towards the mid-20th century, the concept of character disorder, which were seen as enduring problems, are not linked to specific symptoms, but to pervasive internal conflicts or derailments of normal childhood development. These were typically understood as weaknesses of character or willful deviance, and were distinguished from neurosis and psychosis. Meanwhile, a more general personality psychology had been developing in academia and to some extent clinically. Gordon Allport, an American psychologist, was publishing theories of personality traits from the 1920s. In 1936, Allport and Albert found almost 18,000 traits, the terms which have been used to describe human traits. Gordon Allport, known as a trait psychologist, developed a list of 4,500 trait-like words, and he organized them into 3 levels of traits. All port's 3 trait levels are described as follows. Cardinal trait, this is the trait that dominates and shapes a person's behavior. These are the ruling passions, obsessions, such as a need for money and fame. Central trait, this is a general characteristic found in some degrees in every person. These are the basic building blocks that shape most of our behavior, although they are not as overwhelming as cardinal traits. An example of a central trait would be honesty, intelligent, anxious. Secondary trait are sometimes related to attitudes and preferences. These are characteristics seen only in certain circumstances, such as public speaking anxiety and impatience while waiting in line. In 1938, an American Harvard psychologist, Henry Murray, developed the theory of personality and called it personology, which was published in his book entitled, Explorations in Personality. According to Murray, an individual's personality develops dynamically as each person responds to complex elements in her or his specific environment. Murray viewed an individual's entire life as one unit, and pointed out that although a specific element of a person's life can be studied through psychology, the studied episode gives an incomplete picture of the entire life unit. The work of Henry Murray on his theory of personality influenced later a key advocate named Theodore Millon, an American psychologist who is known for his several work in the development of personality disorder, and one of the contributors of the earliest version of DSM. Let's dive in. So, what are personality disorders? It refers to a class of personality types and enduring behaviors associated with significant distress or disability, which appear to deviate from social norms or expectations, particularly in relating to other humans. Those diagnosed with a personality disorder may experience difficulties in cognition, emotiveness, interpersonal functioning or control of impulses. Their behavioral patterns are typically associated with substantial disturbances, usually involving several areas of their personality, and are nearly always associated with considerable personal and social disruption. This behavior can result in maladaptive coping skills, which may lead to personal problems that induce extreme anxiety, distress or depression. In fact, they are too inflexible and pervasive across many situations. This is due in large part to the fact that such behavior may be egocentric. That is, the behavioral patterns are consistent with the ego integrity of the individual, and are, therefore, perceived to be appropriate by that individual. The onset of these patterns of behavior can typically be traced back to early adolescence and the beginning of adulthood, and, in some instances, childhood. In general, personality disorders are diagnosed in 40 to 60% of psychiatric patients, making them the most frequent of all psychiatric diagnoses. They are common and chronic, accounting to about 10 to 20% in the general population. In 2009, a screening survey across 13 countries by the WHO using DSM-4 criteria, reported an estimate of around 6% prevalence for personality disorders. Looking ahead. We can say that a person has a personality disorder if the person meets the following criteria based on the Diagnostic Statistical Manual 5, which are as follows. A. If there is an enduring pattern of inner experience and behavior that deviates markedly from the expectations of the individual's culture, as shown in 2 or more of the following. 1. Cognition, for example perceiving and interpreting the self, other people or events. 2. Affect, for example the range, intensity, lability, and appropriateness of emotional response. 3. Interpersonal functioning. 4. Impulse control. B. The behavioral pattern must appear inflexible and pervasive across a broad range of personal and social situations. C. The enduring pattern leads to clinically significant distress or impairment in social, occupational, or other important areas of functioning. D. The behavioral pattern is stable and of long duration, and its onset can be traced back at least to adolescence or early adulthood. E. The enduring pattern is not better explained as a manifestation or consequence of another mental disorder. F. The enduring pattern is not attributable to the physiological effects of a substance such as illicit drugs or medications, or another medical condition. For example, head trauma. There are 10 personality disorders which are grouped into clusters by their own common features. Cluster A are personality disorders characterized by being odd, eccentric, weird or aloof. These includes paranoid, schizoid and schizotypal personality disorders. Cluster B, on the other hand, are personality disorders characterized by their being dramatic, emotional, erratic or wild. These includes antisocial, borderline, histrionic and narcissistic personality disorders. While the last one, Cluster C, are personality disorders who are fearful, anxious or worried. These are avoidant, dependent, obsessive-compulsive personality disorders. So, what causes personality disorders? The exact cause is still unknown. However, research suggests that several factors between genetic, biological, psychosocial factors may contribute to the development of personality disorders. In the classic nature versus nurture debate, the biological theories of personality side with nature. Researchers believe that there is a link between the genetics and personality traits. According to Kaplan and Sadocks, the best evidence that genetic factors contribute to personality disorders comes from investigations of more than 15,000 pairs of twins in the United States. The concordance for personality disorders among monozygotic twins was several times that among dizygotic twins. In one of the neurobiological research conducted by Kokaro and Seaver in 2005, it was reported that people with schizotypal personality disorder have some of the same brain abnormalities found in people with diagnoses of schizophrenia. These similarities include brain chemicals and structures known to be critically important for the proper functioning of affect, perception, attention, and certain types of memory. This finding informs our understanding of the biological basis of psychotic-like symptoms. This helps us to understand why schizotypal personality disorder occurs more frequently in relatives of people who have schizophrenia than in the general population. Furthermore, people with schizotypal personality disorder appear to be able to compensate for some of these difficulties by relying on other undamaged brain functions. This ability may account for the reason that the schizotypal disorder is not quite as debilitating as schizophrenia. Also, cluster A personality disorders are more common in the biological relatives of patients with schizophrenia than in control groups, especially relatives with schizotypal personality disorder. Cluster B personality disorders apparently have a genetic basis. For example, antisocial personality disorder is associated with alcohol use disorders. Depression is common in the family backgrounds of patients with borderline personality disorder. These patients have more relatives with mood disorders than do control groups. And persons with borderline personality disorder often have a mood disorder as well. Furthermore, a strong association is found between histrionic personality disorder and somatization disorder. They identified a relationship between impulsive aggression and the association of the serotonergic system. This finding suggests there is also a biological, neurological etiology for the symptom of impulsive aggression that is characteristic of cluster B personality disorders, namely, antisocial, borderline, histrionic, narcissistic. In addition, Cluster B personality disorders are also characterized by emotional dysregulation. They reviewed brain imaging studies that found people with cluster B personality disorders, and found out that there is a reduction in the volume of certain brain regions associated with the regulation of emotions. Once again, this finding offers compelling evidence for a biological explanation for the symptom of emotional dysregulation. Cluster C personality disorders may also have a genetic basis. For example, patients with avoidant personality disorder often have high anxiety levels. Obsessive-compulsive traits are more common in monozygotic twins than in dizygotic twins, and patients with obsessive-compulsive personality disorder. While there is less research available for cluster C personality disorders, there are some indications that neurotransmitters, such as dopamine and serotonin, likely play an important role in these disorders as well. One of the best-known biological theorists was Hans Eysenck, who linked aspects of personality to biological processes. He emphasized that personality is influenced by the stress hormone cortisol. According to his theory, introverts have high cortical arousal and avoid stimulation, while extroverts have low cortical arousal and crave stimulation. One of the prominent thinkers in personality development is Sigmund Freud. Sigmund Freud suggested that personality traits are related to a fixation at one psychosexual stage of development. For example, those with an oral character are passive and dependent because they are fixated at the oral stage, when the dependence on others for food is prominent. Those with an anal character are stubborn, parsimonious, and highly conscientious because of struggles over toilet training during the anal period. According to the American Psychological Association, possible contributing factors in the development of personality disorders are trauma, abuse, violence and maladaptive parenting. In one study conducted by Steele in 2019, she described that maladaptive parenting, including childhood maltreatment, abuse and neglect, has been implicated in the scientific literature, exploring the etiology of personality disorder, particularly borderline personality disorder. Every human being has a unique stamp of personality determined by his or her characteristic defense mechanisms. In fact, each person with personality disorder has a cluster of defenses that help psychodynamic clinicians recognize the type of character pathology or type of personality disorder they have. For example, persons with paranoid personality disorder use projection, whereas schizoid personality disorder is associated with withdrawal. In addition, these defenses protects person with personality disorder from internal impulses and from interpersonal anxiety or depression in significant relationships. Wilhelm Reich subsequently coined the term character armor to describe these persons' characteristic defensive styles. In fact, Reich's theory has had a broad influence on contemporary concepts of personality and personality disorders. So, when defenses work effectively for them, persons with personality disorders masters and tries to abolish these feelings of anxiety, depression, anger, shame, guilt, and other effects at the conscious level. Their behavior is egosyntonic, that is, it creates no distress for them even though it may adversely affect others. For them these defenses are so important because it controls unpleasant effects. Because of this, they refuse to abandon these defenses, as abandoning it increases conscious awareness of these unpleasant effects. Which is a major reason that those with personality disorders are reluctant to alter their behavior or engage in a treatment process. Another central feature is internal object relations. According to Kaplan and Sadocks, during childhood development, particular patterns of the self in relation to others are internalized. Through introjection, children internalize a parent or another significant person as an internal presence that continues to feel like an object rather than a self. Through identification, Children internalize parents and others in such a way that the traits of the external object are incorporated into the self and the child owns those traits. These internal self-representations and object representations are crucial in developing the personality and, through externalization and projective identification, these are played out in interpersonal scenarios, in which others are coerced into playing a role in the person's internal life. Thus, persons with personality disorders are also identified by particular patterns of interpersonal relatedness that stem from these internal object relations patterns. Here are some examples of defense mechanisms mentioned in the book by Kaplan and Sadocks, Synopsis of Psychiatry, 11th edition on personality disorders. Please review them carefully in the book. Let's look further. Paranoid personality disorder. The hallmarks of paranoid personality disorder are excessive suspiciousness and mistrust of others expressed as a pervasive tendency to interpret actions of others as deliberately demeaning, malevolent, threatening, exploiting, or deceiving. This behavior usually begins by early adulthood. They frequently dispute, without any justification, friends or associates' loyalty or trustworthiness. Such persons are often pathologically jealous and question the fidelity of their spouses or sexual partners. Persons with this disorder externalize their own emotions and use the defense of projection. They attribute to others the impulses and thoughts that they cannot accept in themselves. Ideas of reference and logically defended illusions are common. Persons with paranoid personality disorder are effectively restricted and appear to be unemotional. They pride themselves on being rational and objective, but such is not the case. They lack warmth and are impressed with, and pay close attention to, power and rank. They express disdain for those they see as weak, sickly, impaired, or defective. In social situations, persons with paranoid personality disorder may appear businesslike and efficient, but they often generate fear or conflict in others. Bigots, injustice collectors, pathologically jealous spouses, and litigious cranks often have paranoid personality disorder. According to DSM-5, person with paranoid personality should have at least 4 or more of the following, beginning by early adulthood. 1. Suspects, without sufficient basis, that others are exploiting, harming, or deceiving him or her. 2. Is preoccupied with unjustified doubts about the loyalty or trustworthiness of friends or associates. 3. Is reluctant to confide in others because of unwarranted fear that the information will be used maliciously against him or her. 4. Reads hidden demeaning or threatening meanings into benign remarks or events. 5. Persistently bears grudges. 6. Perceives attacks on his or her character or reputation that are not apparent to others and is quick to react angrily or to counterattack. 7. Has recurrent suspicions, without justification, regarding fidelity of spouse or sexual partner. Lastly, it does not occur exclusively during the course of schizophrenia, a bipolar disorder or depressive disorder with psychotic features, another psychotic disorder, or autism spectrum disorder neither attributable to the physiological effects of another medical condition. Prevalence of paranoid personality disorder is 2 to 4% of the general population. Those with the disorder rarely seek treatment themselves. When referred to treatment by a spouse or an employer, they can often pull themselves together and appear undistressed. Management and treatment. Psychotherapy is the treatment of choice for those with paranoid personality disorder. To manage this type of patients, the therapist should be straightforward in all their dealings with these patients. If a therapist is accused of inconsistency or a fault, such as lateness for an appointment, honesty and an apology are preferable to a defensive explanation. Therapists must remember that trust and toleration of intimacy are troubled areas for patients with this disorder. Individual psychotherapy thus requires a professional and not overly warm style from therapists. Clinicians' overuse of interpretation, especially interpretation about deep feelings of dependence, sexual concerns, and wishes for intimacy, may increase patients' mistrust significantly. Patients who are paranoid usually do not do well in group psychotherapy, although it can be useful for improving social skills and diminishing suspiciousness through role-playing. At times, patients with paranoid personality disorder behave so threateningly that therapists must control or set limits on their actions. Delusional accusations must be dealt with realistically but gently and without humiliating patients. Patients who are paranoid are profoundly frightened when they feel that those trying to help them are weak and helpless. Therefore, therapists should never offer to take control unless they are willing and able to do so. Pharmacotherapy is useful in dealing with agitation and anxiety. In most cases, an anti-anxiety agent such as benzodiazepine suffices. It may be necessary, however, to use an antipsychotic such as haloperidol in small dosages and for brief periods to manage severe agitation or restless patients. Schizoid personality disorder. The main feature of schizoid personality disorder is characterized by a long lasting of social withdrawal. Persons with schizoid personality disorder are often seen by others as eccentric, isolated, or lonely. Their discomfort with human interaction, their introversion, and their bland, constricted affect are noteworthy to mention. Persons with schizoid personality disorder seem to be cold and aloof. They display a remote reserve and show no involvement with everyday events and the concerns of others. They appear quiet, distant, seclusive, and unsociable. They may pursue their own lives with remarkably little need or longing for emotional ties, and they are the last to be aware of changes in popular fashion. The life histories of such persons reflect solitary interests and success at non-competitive, lonely jobs that others find difficult to tolerate. Their sexual lives may exist exclusively in fantasy, and they may postpone mature sexuality indefinitely. Men may not marry because they are unable to achieve intimacy. On the other hand, women may passively agree to marry an aggressive man who wants the marriage. Persons with schizoid personality disorder usually reveal a lifelong inability to express anger directly. They can invest enormous affective energy in non-human interests, such as mathematics and astronomy, and they may be very attached to animals. Dietary and health fads, philosophical movements, and social improvement schemes, especially those that require no personal involvement, often engross them. Although persons with schizoid personality disorder appear self-absorbed and lost in daydreams, they have a normal capacity to recognize reality. Because aggressive acts are rarely included in their repertoire of usual responses, most threats, real or imagined, are dealt with by fantasized omnipotence or resignation. According to DSM-5, person with schizoid personality should have at least 4 or more of the following, beginning by early adulthood. 1. Neither desires nor enjoys close relationships, including being part of a family. 2. Almost always chooses solitary activities. 3. Has little, if any, interest in having sexual experiences with another person. 4. Takes pleasure in few, if any, activities. 5. Lacks close friends or confidants other than first-degree relatives. 6. Appears indifferent to the praise or criticism of others. Shows emotional coldness, detachment, or flattened affectivity. Lastly, it does not occur exclusively during the course of schizophrenia, a bipolar disorder or depressive disorder with psychotic features, another psychotic disorder, or autism spectrum disorder, neither attributable to the physiological effects of another medical condition. The prevalence of schizoid personality disorder may affect 5% of the general population. The sex ratio of the disorder is unknown. Some studies report a 2-to-1 male-to-female ratio. Persons with the disorder tend to lean towards solitary jobs that involve little or no contact with others. Many prefer night work compared to day work so that they need not deal with many persons. Psychotherapy. The treatment of patients with schizoid personality disorder is similar to that of those with paranoid personality disorder. Patients who are schizoid tend toward introspection. However, these tendencies are consistent with psychotherapists' expectations, and such patients may become devoted, if distant, patients. As trust develops, patients who are schizoid may reveal excessive amount of fantasies, imaginary friends, and fears of unbearable dependence, even of merging with the therapist. In group therapy settings, patients with schizoid personality disorder may be silent for long periods. Nonetheless, they do become involved. The patients should be protected against aggressive attack by group members for their behavior of being silent. With time, the group members become important to patients who are schizoid and may provide the only social contact in their otherwise isolated existence. Pharmacotherapy. Pharmacotherapy with small dosages of antipsychotic, antidepressants, and psychostimulants has benefited some patients. Serotonergic agents may make patients less sensitive to rejection. Benzodiazepines may help diminish interpersonal anxiety. Schizotypal personality disorder. The main features of a schizotypal personality disorder are strikingly odd or strange, even to lay persons. Magical thinking, peculiar notions, ideas of reference, illusions, and derealization are part of a schizotypal person's everyday world. Patients with schizotypal personality disorder exhibit disturbed thinking and communicating. Although frank thought disorder is absent, their speech may be distinctive or peculiar, may have meaning only to them, and often needs interpretation. Comparing them with schizophrenia, those with schizotypal personality disorder may not know their own feelings and yet are sensitive to, and aware of, the feelings of others, especially negative affects such as anger. These patients may be superstitious or claim powers of clairvoyance and may believe that they have other special powers of thought and insight. Their inner world may be filled with vivid imaginary relationships and childlike fears and fantasies. They may admit to perceptual illusions or macropsia and confess that other persons seem wooden and all the same. Furthermore, they have poor interpersonal relationships and may act inappropriately. They are isolated and have few, if any, friends. Under stress, patients with schizotypal personality disorder may decompensate and have psychotic symptoms, but these are usually brief. In severe cases of the disorder may exhibit anhedonia and severe depression. According to current clinical thinking, the schizotype is the premorbid personality of the patient with schizophrenia. Some, however, maintain a stable schizotypal personality throughout their lives and marry and work, despite their strange behavior. In one study by Thomas McGlashan reported that 10% of those with schizotypal personality disorder eventually committed suicide. According to DSM-5, person with schizotypal personality should have at least 5 or more of the following, beginning by early adulthood. 1. Ideas of reference. 2. Odd beliefs or magical thinking that influences behavior and is inconsistent with subcultural norms. 3. Unusual perceptual experiences, including bodily illusions. 4. Odd thinking and speech. Suspiciousness or paranoid ideation. 5. Inappropriate or constricted affect. 6. behavior or appearance that is odd, eccentric, or peculiar. 7. Lack of close friends or confidants other than first-degree relatives. 8. Excessive social anxiety that does not diminish with familiarity and tends to be associated with paranoid fears rather than negative judgments about self. Lastly, it does not occur exclusively during the course of schizophrenia, a bipolar disorder or depressive disorder with psychotic features, another psychotic disorder, or autism spectrum disorder neither attributable to the physiological effects of another medical condition. Schizotypal personality disorder occurs in about 3% of the general population. The sex ratio is unknown. However, it is frequently diagnosed in females with Fragile X syndrome. DSM-5 suggests the disorder may be slightly more common in males. A greater association of cases exists among the biological relatives of patients with schizophrenia than among control participants and a higher incidence among monozygotic twins, about 33%, than among dizygotic twins, which is 4% only. Adoption, family, and twin studies also demonstrate an increased prevalence of schizotypal features in the families of schizophrenic patients, especially when schizotypal were not associated with comorbid affective symptoms. Psychotherapy. The principles of treatment of schizotypal personality disorder do not differ from those of schizoid personality disorder. These patients have peculiar patterns of thinking, and some are involved in cults, strange religious practices, and the occult. In managing this type of patients, therapists must not ridicule such activities or be judgmental about these beliefs or activities. Pharmacotherapy. Antipsychotic medication may be useful in dealing with ideas of reference, illusions, and other symptoms of the disorder and can be used in conjunction with psychotherapy. Antidepressants are useful when a depressive component of the personality is present. Antisocial personality disorder. Antisocial personality disorder is an inability to conform to the social norms that ordinarily govern many aspects of a person's adolescent and adult behavior. Although characterized by continuous antisocial or criminal acts, the disorder is not synonymous with criminality. Patients with antisocial personality disorder can often seem to be normal and even charming or ingratiating. Their histories, however, reveal many areas of disordered life functioning. Lying, truancy, running away from home, thefts, fights, substance abuse, and illegal activities are typical experiences that patients report as beginning in childhood. These patients often impress opposite-sex clinicians with the colorful, seductive aspects of their personalities, but same-sex clinicians may regard them as manipulative and demanding. They exhibit no anxiety or depression, a lack that may seem grossly incongruous with their situations, although suicide threats and somatic preoccupations may be common. Their own explanations of their antisocial behavior make it seem mindless, but their mental content reveals the complete absence of delusions and other signs of irrational thinking. In fact, they frequently have a heightened sense of reality testing and often impress observers as having good verbal intelligence. Persons with antisocial personality disorder are highly representative of so-called con men. They are extremely manipulative and can frequently talk others into participating in schemes for easy ways to make money or to achieve fame or notoriety. These schemes may eventually lead the unwary to financial ruin or social embarrassment or both. Those with this disorder do not tell the truth, and cannot be trusted to carry out any task or adhere to any conventional standard of morality. Promiscuity, spousal abuse, child abuse, and drunk driving are common events in their lives. A notable finding is a lack of remorse or empathy for these actions. That is, they appear to lack a conscience. When an antisocial personality disorder develops, it runs an unremitting course, with the height of antisocial behavior usually occurring in late adolescence. The prognosis varies. Symptoms decrease as persons grow older. Many patients have somatization disorder and multiple physical complaints. Depressive disorders, alcohol use disorders, and other substance abuse are common. Patients with antisocial personality disorder can fool even the most experienced clinicians. In an interview, patients can appear composed and credible, but beneath that mask of sanity lurks tension, hostility, irritability, and rage. A stress interview, in which patients are vigorously confronted with inconsistencies in their histories, may be necessary to reveal the pathology. A diagnostic workup should include a thorough neurological examination. Because patients often show abnormal EEG results and soft neurological signs suggesting minimal brain damage in childhood, these findings can be used to confirm the clinical impression. According to DSM-5, person with antisocial personality should have at least 3 or more of the following, occurring since age 15 years. 1. Failure to conform to social norms with respect to lawful behaviors, as indicated by repeatedly performing acts that are grounds for arrest. 2. Deceitfulness, as indicated by repeated lying, use of aliases, or conning others for personal profit or pleasure. 3. Impulsivity or failure to plan ahead. 4. Irritability and aggressiveness, as indicated by repeated physical fights or assaults. 5. Reckless disregard for safety of self or others. 6. Consistent irresponsibility, as indicated by repeated failure to sustain consistent work behavior or honor financial obligations. 7. Lack of remorse, as indicated by being indifferent to or rationalizing having hurt, mistreated, or stolen from another. 8. The age should be at least 18 years of age. 9. There must be a history of conduct disorder before age 15 years old. Lastly, it does not occur exclusively during the course of schizophrenia, a bipolar disorder or depressive disorder with psychotic features, another psychotic disorder, or autism spectrum disorder neither attributable to the physiological effects of another medical condition or a substance. The 12-month prevalence rates of antisocial personality disorder are between 0.2 and 3% according to DSM-5. It is more common in poor urban areas and among mobile residents of these areas, where it is found among the most severe samples of men with alcohol use disorder, over 70% in prison populations. The onset of the disorder is before the age of 15 years. Girls usually have symptoms before puberty and boys even earlier. A familial pattern is present. The disorder is 5 times more common among first-degree relatives of men with the disorder than among control participants. Psychotherapy. If patients with antisocial personality disorder are immobilized, for example, placed in hospitals, they often become amenable to psychotherapy. When patients feel that they are among peers, their lack of motivation for change disappears. Perhaps for this reason, self-help groups have been more useful than jails in alleviating the disorder. Before treatment can begin, firm limits are essential. Therapists must find ways of dealing with patients' self-destructive behavior. And to overcome patients' fear of intimacy, therapists must frustrate patients' desire to run from honest human encounters. In doing so, therapists face the challenge of separating control from punishment and of separating help and confrontation from social isolation and retribution. Pharmacotherapy is used to deal with incapacitating symptoms such as anxiety, rage, and depression, but because patients are often substance abusers, drugs must be used judiciously. Attempts have been made to alter catecholamine metabolism with drugs and to control impulsive behavior with anti-epileptic drugs, for example, carbamazepine or valproate, especially if abnormal waveforms are noted on an EEG. Beta-adrenergic receptor antagonists have been used to reduce aggression. Borderline personality disorder. The main features of a borderline personality disorder is the extreme black and white thinking, instability in relationships, self-image, identity and behavior often leading to self-harm and impulsivity. Patients with borderline personality disorder stand on the border between neurosis and psychosis, and they are characterized by extraordinarily unstable affect, mood, behavior, object relations, and self-image. The disorder has also been called ambulatory schizophrenia, as if personality. This is term coined by Helene Deutsch. Pseudoneurotic schizophrenia as described by Paul Hawke and Philip Politan. Persons with borderline personality disorder almost always appear to be in a state of crisis. Mood swings are common. Patients can be argumentative at one moment, depressed the next, and later complain of having no feelings. Patients can have short-lived psychotic episodes, so-called micropsychotic episodes rather than full-blown psychotic breaks, and the psychotic symptoms of these patients are almost always circumscribed, fleeting, or doubtful. The behavior is highly unpredictable, and their achievements are rarely at the level of their abilities. The painful nature of their lives is reflected in repetitive self-destructive acts, such as slashing their wrists and perform other self-mutilations to elicit help from others, to express anger, or to numb themselves to overwhelming affect. Persons with this disorder have disturbed interpersonal relationships. They can be dependent on those with whom they are close and, when frustrated, can express enormous anger toward their intimate friends. They cannot tolerate being alone, and they prefer a frantic search for companionship, no matter how unsatisfactory, to their own company. To assuage loneliness, if only for brief periods, they accept a stranger as a friend or behave promiscuously. They often complain about chronic feelings of emptiness and boredom and the lack of a consistent sense of identity. When under pressure, they often complain about how depressed they usually feel. Otto Kernberg described the defense mechanism of projective identification that occurs in patients with borderline personality disorder. In this primitive defense mechanism, intolerable aspects of the self are projected onto another. The other person is induced to play the projected role, and the two persons act in unison. Functionally, patients with borderline personality disorder distort their relationships by considering each person to be either all good or all bad. They see persons as either nurturing attachment figures or as hateful, sadistic figures who deprive them of security needs and threaten them with abandonment whenever they feel dependent. As a result of this splitting, the good person is idealized and the bad person devalued. Shifts of allegiance from one person or group to another are frequent. According to DSM-5, person with borderline personality should have at least 5 or more of the following, beginning by early adulthood. 1. Frantic efforts to avoid real or imagined abandonment. 2. A pattern of unstable and intense interpersonal relationships characterized by alternating between extremes of idealization and devaluation. 3. Identity disturbance, markedly and persistently unstable self-image and sense of self. 4. Impulsivity in at least 2 areas that are potentially self-damaging. 5. Recurrent suicidal behavior, gestures, or threats, or self-mutilating behavior. 6. Affective instability due to a marked reactivity of mood. 7. Chronic feelings of emptiness. 8. Inappropriate, intense anger or difficulty controlling anger. 9. Transient, stress-related paranoid ideation or severe dissociative symptoms. No definitive prevalence studies are available, but borderline personality disorder is thought to be present in about 1 to 2% of the population and is twice as common in women as in men. An increased prevalence of major depressive disorder, alcohol use disorders, and substance abuse, which is found in first-degree relatives of persons with borderline personality disorder. Borderline personality disorder is fairly stable. Patients change little over time. Longitudinal studies show no progression towards schizophrenia, but patients have a high incidence of major depressive episodes. The diagnosis is usually made before the age of 40 years, when patients are attempting to make occupational, marital, and other choices and are unable to deal with the normal stages of the life cycle. Psychotherapy for patients with borderline personality disorder has been the treatment of choice. For best results, pharmacotherapy has been added to the treatment regimen. Psychotherapy is difficult for the patient and therapist alike. Patients regress easily, act out their impulses, and show label or fixed negative or positive transferences, which are difficult to analyze. Projective identification may also cause countertransference problems when therapists are unaware the patients are unconsciously trying to coerce them to act out a particular behavior. The splitting defense mechanism causes patients to alternately love and hate therapists and others in the environment. A reality-oriented approach is more effective than in-depth interpretations of the unconscious. Therapists have used behavior therapy to control patients' impulses and angry outbursts and to reduce their sensitivity to criticism and rejection. Social skills training, especially with videotape playback, helps enable patients to see how their actions affect others and thereby improve their interpersonal behavior. Patients with borderline personality disorder often do well in a hospital setting in which they receive intensive psychotherapy on both an individual and a group basis. In a hospital, they can also interact with trained staff members from a variety of disciplines and can be provided with occupational, recreational, and vocational therapy. Such programs are especially helpful when the home environment is detrimental to a patient's rehabilitation because of intrafamilial conflicts or other stresses, such as parental abuse. Within the protected environment of the hospital, patients who are excessively impulsive, self-destructive, or self-mutilating can be given limits, and their actions can be observed. Under ideal circumstances, patients remain in the hospital until they show marked improvement, up to 1 year in some cases. Patients can then be discharged to special support systems, such as day hospitals, night hospitals, and halfway houses. Dialectical behavioral therapy, helpful in borderline patients with parasuicidal behavior. Mentalization-based therapy, MBT, is based on a theory that borderline personality symptoms, such as difficulty regulating emotions and managing impulsivity, are a result of patients' reduced capacities to mentalize. Thus, it is believed that recovery of mentalization helps patients build relationship skills as they learn to better regulate their thoughts and feelings. Pharmacotherapy. Antipsychotics have been used to control anger, hostility, and brief psychotic episodes. Antidepressants improve the depressed mood common in patients with borderline personality disorder. The MAO inhibitors have successfully modulated impulsive behavior in some patients. Benzodiazepines, particularly alprazolam Xanax, help anxiety and depression, but some patients show a disinhibition with this class of drugs. Anticonvulsants, such as carbamazepine, may improve global functioning for some patients. Serotonergic agents such as selective serotonin reuptake inhibitors have been helpful in some cases. Histrionic personality disorder. The main feature of a histrionic personality disorder is pervasive attention-seeking behavior including inappropriately seductive behavior and shallow or exaggerated emotions. Persons with histrionic personality disorder are generally cooperative, excitable, emotional and behave in a colorful, dramatic, extroverted fashion. Gestures and dramatic punctuation in their conversations are common. Accompanying their flamboyant aspects, however, is often an inability to maintain deep, long-lasting attachments. Persons with histrionic personality disorder show a high degree of attention-seeking behavior. They tend to exaggerate their thoughts, feelings and make everything sound more important than it really is. They display temper tantrums, tears, and accusations when they are not the center of attention or are not receiving praise or approval. Seductive behavior is common in both sexes. Sexual fantasies about persons with whom patients are involved are common, but are inconsistent about verbalizing these fantasies and may be coy or flirtatious rather than sexually aggressive. In fact, histrionic patients may have a psychosexual dysfunction. Women may be anorgasmic, and men may be impotent. Their need for reassurance is endless. They may act on their sexual impulses to reassure themselves that they are attractive to the other sex. Their relationships tend to be superficial. They can be vain, self-absorbed, and fickle. Their strong dependence needs make them overly trusting and gullible. The major defenses of patients with histrionic personality disorder are repression and dissociation. With such, patients are unaware of their true feelings and cannot explain their motivations. When pressured to acknowledge certain feelings, for example, anger, sadness, and sexual wishes, they may respond with surprise, indignation, or denial. According to DSM-5, person with histrionic personality should have at least 5 or more of the following, beginning by early adulthood. 1. Is uncomfortable in situations in which he or she is not the center of attention. 2. Interaction with others is often characterized by inappropriate sexually seductive or provocative behavior. 3. Displays rapidly shifting and shallow expression of emotions. 4. Consistently uses physical appearance to draw attention to self. 5. Has a style of speech that is excessively impressionistic and lacking in detail. 6. Shows self-dramatization, theatricality, and exaggerated expression of emotion. 7. Is suggestible. 8. Considers relationships to be more intimate than they actually are. Limited data from general population studies suggest a prevalence of histrionic personality disorder of about 1 to 3%. Rates of about 10 to 15% have been reported in inpatient and outpatient mental health settings when structured assessment is used. The disorder is diagnosed more frequently in women than in men. Some studies have found an association with somatization disorder and alcohol use disorders. With age, persons with histrionic personality disorder show fewer symptoms, but because they lack the energy of earlier years, the difference in number of symptoms may be more apparent than real. Persons with this disorder are sensation seekers, and they may get into trouble with the law, abuse substances, and act promiscuously. Psychotherapy. Patients with histrionic personality disorder are often unaware of their own real feelings. Thus, as a therapist, clarification of their inner feelings is an important therapeutic process. Psychoanalytically oriented psychotherapy, whether group or individual, is probably the treatment of choice for histrionic personality disorder. Pharmacotherapy. Pharmacotherapy can be adjunctive when symptoms are targeted, for example, the use of antidepressants for depression and somatic complaints, anti-anxiety agents for anxiety, and antipsychotic for derealization and illusions. Narcissistic personality disorder. The main feature of a person with narcissistic personality disorder is a pervasive pattern of grandiosity, need for admiration, and a lack of empathy. Characterized by self-importance, preoccupations with fantasies, belief that they are special, including a sense of entitlement and a need for excessive admiration, and extreme levels of jealousy and arrogance. Underneath, however, their self-esteem is fragile and vulnerable to even minor criticism. Persons with narcissistic personality disorder consider themselves special and expect special treatment. Their sense of entitlement is striking. They handle criticism poorly and may become enraged when someone dares to criticize them, or they may appear completely indifferent to criticism. Persons with this disorder want their own way and are frequently ambitious to achieve fame and fortune. Their relationships are tenuous, and they can make others furious by their refusal to obey conventional rules of behavior. They cannot show empathy, and they feign sympathy only to achieve their own selfish ends. Because of their fragile self-esteem, they are susceptible to depression. Interpersonal difficulties, occupational problems, rejection, and loss are among the stresses that narcissists commonly produce by their behavior. According to DSM-5, person with narcissistic personality should have at least 5 or more of the following, beginning by early adulthood. 1. Has a grandiose sense of self-importance. 2. Is preoccupied with fantasies of unlimited success, power, brilliance, beauty, or ideal love. 3. Believes that he or she is special and unique and can only be understood by, or should associate, other special or high-status people. 4. Requires excessive admiration. 5. Has a sense of entitlement. 6. Is interpersonally exploitative. 7. Lacks empathy, is unwilling to recognize or identify with the feelings and needs of others. 8. Is often envious of others or believes that others are envious of him or her. 9. Shows arrogant, haughty behaviors or attitudes. The prevalence of narcissistic personality disorder range from less than 1 to 6% in community samples. Persons with the disorder may impart an unrealistic sense of omnipotence, grandiosity, beauty, and talent to their children. Thus, offspring of such parents may have a higher than usual risk for developing the disorder themselves. It is chronic and difficult to treat. Patients with the disorder must constantly deal with blows to their narcissism resulting from their own behavior or from life experience. Aging is handled poorly. Patients value beauty, strength, and youthful attributes, to which they cling inappropriately. They may be more vulnerable, therefore, to midlife crisis than other groups. Psychotherapy. Because patients must renounce their narcissism to make progress, the treatment of narcissistic personality disorder is difficult. Some clinicians advocate group therapy for their patients so they can learn how to share with others and, under ideal circumstances, can develop an empathic response to others. Pharmacotherapy. Lithium has been used with mood swings. Because patients with narcissistic personality disorder tolerate rejection poorly and are susceptible to depression, antidepressants, especially serotonergic drugs, may also be of use. Avoidant personality disorder. The main feature of a person with avoidant personality disorder is pervasive feelings of social inhibition and social inadequacy, extreme sensitivity to negative evaluation and avoidance of social interaction. Persons with avoidant personality disorder show extreme sensitivity to rejection and may lead socially withdrawn lives. Although shy, they are not asocial and show a great desire for companionship, but they need unusually strong guarantees of uncritical acceptance. Such persons are commonly described as having an inferiority complex. Hypersensitivity to rejection by others is the central clinical feature of avoidant personality disorder, and patients' main personality trait is timidity. These persons desire the warmth and security of human companionship but justify their avoidance of relationships by their alleged fear of rejection. When talking with someone, they express uncertainty, show a lack of self-confidence, and may speak in a self-effacing manner. Because of fear of rejection, they are afraid or anxious to speak up in public, do interviews or to make requests of others. They are apt to misinterpret other persons' comments as derogatory or ridiculing. The refusal of any request leads them to withdraw from others and to feel hurt. At work, they are often take jobs on the sidelines. They rarely attain much personal advancement or exercise much authority but seem shy and eager to please. These persons are generally unwilling to enter relationships unless they are given an unusually strong guarantee of uncritical acceptance. Consequently, they often have no close friends or confidants. According to DSM-5, person with avoidant personality should have at least 4 or more of the following, beginning by early adulthood. 1. Avoids occupational activities that involve significant interpersonal contact because of fears of criticism, disapproval, or rejection. 2. Is unwilling to get involved with people unless certain of being liked. 3. Shows restraint within intimate relationships because of the fear of being shamed or ridiculed. 4. Is preoccupied with being criticized or rejected in social situations. 5. Is inhibited in new interpersonal situations because of feelings of inadequacy. 6. Views self as socially inept, personally unappealing, or inferior to others. 7. Is unusually reluctant to take personal risks or to engage in any new activities because they may prove embarrassing. The prevalence of the disorder is suggested to be about 2 to 3% of the general population according to DSM-5. No information is available on sex ratio or familial pattern. Infants classified as having a timid temperament may be more susceptible to the disorder. Many persons with avoidant personality disorder are able to function in a protected environment. Some marry, have children, and live their lives surrounded only by family members. If their support system fails, however, they are subject to depression, anxiety, and anger. Phobic avoidance is common, and patients with the disorder may give histories of social phobia or incurred social phobia in the course of their illness. Psychotherapy. Psychotherapeutic treatment depends on solidifying an alliance with patients. As trust develops, a therapist must convey an accepting attitude toward the patient's fears, especially the fear of rejection. The therapist eventually encourages a patient to move out into the world to take what are perceived as great risks of humiliation, rejection, and failure. But therapists should be cautious when giving assignments to exercise new social skills outside therapy. Failure can reinforce a patient's already poor self-esteem. Group therapy may help patients understand how their sensitivity to rejection affects them and others. Assertiveness training is a form of behavior therapy that may teach patients to express their needs openly and to enlarge their self-esteem. Pharmacotherapy. Pharmacotherapy has been used to manage anxiety and depression when they are associated with the disorder. Beta-adrenergic antagonists, such as propranolol or atenolol, to manage autonomic nervous system hyperactivity, which tends to be high in patients with avoidant personality disorder, especially when they approach feared situations. Serotonergic agents may help rejection sensitivity. Theoretically, dopaminergic drugs might cause novelty-seeking behavior in these patients. However, the patient must be psychologically prepared for any new experience that might result. Dependent personality disorder. The main feature of a person with dependent personality disorder is a pervasive psychological dependence on other people. Persons with dependent personality disorder subordinate their own needs to those of others, get others to assume responsibility for major areas of their lives, lack self-confidence, and may experience intense discomfort when alone for more than a brief period. The disorder has been called passive dependent personality. Freud described an oral dependent personality dimension characterized by dependence, pessimism, fear of sexuality, self-doubt, passivity, suggestibility, and lack of perseverance. In fact, Persons with the disorder cannot make decisions without an excessive amount of advice and reassurance from others. They avoid positions of responsibility and become anxious if asked to assume a leadership role. They prefer to be submissive. When on their own, they find it difficult to persevere at tasks but may find it easy to perform these tasks for someone else. Because persons with the disorder do not like to be alone, they seek out others on whom they can depend. Their relationships, thus, are distorted by their need to be attached to another person. In folia du shared psychotic disorder, one member of the pair usually has dependent personality disorder. The submissive partner takes on the delusional system of the more aggressive, assertive partner on whom he or she depends. Pessimism, self-doubt, passivity, and fears of expressing sexual and aggressive feelings all typify the behavior of persons with dependent personality disorder. An abusive, unfaithful, or alcoholic spouse may be tolerated for long periods to avoid disturbing the sense of attachment. Occupational functioning tends to be impaired because persons with the disorder cannot act independently and without close supervision. Social relationships are limited to those on whom they can depend, and many suffer physical or mental abuse because they cannot assert themselves. They risk major depressive disorder if they lose the person on whom they depend, but with treatment, the prognosis is favorable. According to DSM-5, person with dependent personality should have at least 5 or more of the following, beginning by early adulthood. 1. Has difficulty making everyday decisions without an excessive amount of advice and reassurance from others. 2. Needs others to assume responsibility for most major areas of his or her life. 3. Has difficulty expressing disagreement with others because of fear of loss of support or approval. 4. Has difficulty initiating projects or doing things on his or her own. 5. Goes to excessive lengths to obtain nurturance and support from others, to the point of volunteering to do things that are unpleasant. 6. Feels uncomfortable or helpless when alone because of exaggerated fears of being unable to care for himself or herself. 7. Urgently seeks another relationship as a source of care and support when a close relationship ends. 8. Is unrealistically preoccupied with fears of being left to take care of himself or herself. Dependent personality disorder is more common in women than in men. DSM-5 reports an estimated prevalence of 0.6%. It is more common in young children than in older ones. Persons with chronic physical illness in childhood may be most susceptible to the disorder. Psychotherapy. Insight-oriented therapies enable patients to understand the antecedents of their behavior, and with the support of a therapist, patients can become more independent, assertive, and self-reliant. Behavioral therapy, assertiveness training, family therapy, and group therapy have all been used, with successful outcomes in many cases. A downfall may arise in treatment when a therapist encourages a patient to change the dynamics of a pathological relationship, for example, supports a physically abused wife in seeking help from the police. At this point, patients may become anxious and unable to cooperate in therapy. They may feel torn between complying with the therapist and losing a pathological external relationship. Therapists must show great respect for these patients' feelings of attachment, no matter how pathological these feelings may seem. Pharmacotherapy. This can be used to deal with specific symptoms, such as anxiety and depression, which are common associated features of dependent personality disorder. Patients who experience panic attacks or who have high levels of separation anxiety may be helped by imipramine tofranil. Benzodiazepines and serotonergic agents have also been useful. Obsessive-compulsive personality disorder. The main feature of a person with obsessive-compulsive personality disorder is a pervasive pattern of perfectionism and inflexibility. Persons with obsessive-compulsive personality disorder are preoccupied with rules, regulations, orderliness, neatness, details, and the achievement of perfection. These traits account for the general emotional constriction of the entire personality. They insist that rules be followed rigidly and cannot tolerate what they consider infractions. They lack flexibility and are intolerant. They are capable of prolonged work, provided it is routine and does not require changes to which they cannot adapt. Persons with obsessive-compulsive personality disorder have limited interpersonal skills. They are formal, serious and often lack a sense of humor. They alienate persons, are unable to compromise, and insist that others submit to their needs. They are eager to please those whom they see as more powerful than they are, however, and they carry out these persons' wishes in an authoritarian manner. Because they fear making mistakes, they are indecisive and ruminate about making decisions. Although a stable marriage and occupational adequacy are common, persons with obsessive-compulsive personality disorder have few friends. Anything that threatens to upset their perceived stability or the routine of their lives can precipitate much anxiety. The defense mechanisms they use are rationalization, isolation, intellectualization, reaction formation, and undoing. According to DSM-5, person with obsessive-compulsive personality should have at least 4 or more of the following, beginning by early adulthood. 1. Is preoccupied with details, rules, lists, order, organization, or schedules to the extent that the major point of the activity is lost. 2. Shows perfectionism that interferes with task completion. 3. Is excessively devoted to work and productivity to the exclusion of leisure activities and friendships. 4. Is over-conscientious, scrupulous, and inflexible about matters of morality, ethics, or values. 5. Is unable to discard worn-out or worthless objects even when they have no sentimental value. 6. Is reluctant to delegate tasks or to work with others unless they submit to exactly his or her way of doing things. 7. Adopts a miserly spending style toward both self and others. Money is viewed as something to be hoarded for future catastrophes. 8. Shows rigidity and stubbornness. DSM-5 reports an estimated prevalence ranging from 2 to 8%. It is more common in men than in women and is diagnosed most often in oldest siblings. The disorder also occurs more frequently in first-degree biological relatives of persons with the disorder than in the general population. Patients often have backgrounds characterized by harsh discipline. Freud hypothesized that the disorder is associated with difficulties in the anal stage of psychosexual development, generally around the age of 2 years, but various studies have failed to validate this theory. The course of obsessive-compulsive personality disorder is variable and unpredictable. From time to time, persons may develop obsessions or compulsions in the course of their disorder. Some adolescents with obsessive-compulsive personality disorder evolve into warm, open, and loving adults. In others, the disorder can be either the harbinger of schizophrenia and exacerbated by the aging process major depressive disorder, which is more common. Psychotherapy. Unlike other personality disorders, obsessive-compulsive personality disorder are often aware of their suffering, and they seek treatment on their own. Overtrained and over-socialized, these patients value free association and no directive therapy highly. Treatment is often long and complex, and countertransference problems are common. Group therapy and behavior therapy occasionally offer certain advantages. Preventing the completion of their habitual behavior raises patients' anxiety and leaves them susceptible to learning new coping strategies. Patients can also receive direct rewards for a change in group therapy, something less often possible in individual psychotherapies. Pharmacotherapy. Clonazepam, a benzodiazepine with anticonvulsant use, has reduced symptoms in patients with severe obsessive-compulsive disorder. Whether is of use in the personality disorder is unknown. Clomipramine, and such serotonergic agents as fluoxetine, usually at dosages of 60 to 80 mg a day, may be useful if obsessive-compulsive signs and symptoms break through. My references for this lecture are shown below. All images credited to their respective owners. This ends my lecture. If you have any questions or comments, please do not hesitate to contact me with the email provided in this slide. Thank you for listening.